Welcome back to the Deep Dive. Today, we're opening up a topic that is, frankly, terrifying, mostly because of how quietly it stalks its victims. We're talking about gallbladder cancer. And depending on where you are listening to this from, this is either a medical curiosity you might see once in a decade or a massive public health crisis you face every week.
It is a study in contrasts, a real one.
Yeah.
If you are practicing in the U.S. or, say, Western Europe, you might call this an orphan cancer. It's rare. But if you shift your gaze to the Indo-Gangetic belt in India or down to Chile or over to Japan, the narrative changes completely. In those regions, it is highly aggressive, it's prevalent, and it is lethal.
And that lethality is what we really need to confront today. We are basing this deep dive on the comprehensive text, Gallbladder Cancer, Current Treatment Options, edited by the team of Shukla, Pandey, and Dixit. And I want to set the expectation right now. We aren't just skimming the surface. We are approaching this as medical educators today.
We have to. The source material is dense because the stakes are so high. We're looking at an overall 5-year survival rate of less than 5%. That is a grim statistic. So our mission is to walk through the epidemiology, the unique surgical anatomy, which is really the villain here, and finally, the cutting-edge molecular targets that might actually change those numbers.
Okay, let's start with that who and where. You mentioned the geography, India, Chile, Japan. It feels a bit random. Is there a common thread connecting these populations?
It seems random until you look at the triggers. It's a mix of genetic predisposition and, well, chronic irritation. But if you want to find the smoking gun, you have to look for the stones. Cholelithiasis.
Gallstones are incredibly common, though. I mean, I know plenty of people who've had their gallbladder out because of stones, and cancer was never even part of the discussion.
And that's the nuance. About 85% of patients with gallbladder cancer do have gallstones. But the reverse isn't true. Most people with stones won't get cancer. The source material highlights a very specific risk multiplier. It comes down to size.
Size matters.
Crucially, we are talking about stones greater than 3 centimeters. If a patient is carrying around a stone that large, their risk of developing carcinoma jumps tenfold compared to someone with smaller stones.
Tenfold is a massive epidemiological signal. I mean, what is a stone that big actually doing inside the organ?
It's chronic mechanical trauma. Just imagine a rock tumbling around inside a washing machine day after day, year after year. That constant friction causes chronic inflammation of the mucosa. That inflammation drives the cellular turnover, which eventually drives carcinogenesis. It's a slow-motion injury that never heals.
And it's not just mechanical, right? I remember the text mentions biological irritants, too.
Right. Chronic infection plays a huge role. Specifically Salmonella typhi, the bacteria that causes typhoid. If someone is a chronic carrier, that bacteria just colonizes the gallbladder. It forms a biofilm on the stones themselves. Helicobacter species are also implicated. It's the same theme: persistent, low-grade inflammation leading to DNA damage over decades.
There's also an anatomical issue mentioned, something called the APBJ. It sounds like a plumbing disaster.
That is the perfect way to describe it. The anomalous pancreatico-biliary junction, or APBJ, it's significantly more common in East Asian populations. Normally, the bile duct and the pancreatic duct join right at the wall of the intestine, the duodenum. In APBJ, they join way too early, outside the duodenal wall.
So the sphincter that usually stops backflow isn't working properly.
Exactly. It allows pancreatic juices, which are rich in proteolytic enzymes meant to digest food, to reflux up into the biliary tree. So you have pancreatic enzymes chemically burning the lining of the gallbladder for years. It's a recipe for malignancy.
There's one other demographic detail that really stood out to me in the reading. This is the only gastrointestinal tumor with a female predominance. Usually GI cancers lean male. Why is the gallbladder different?
It's a fascinating paradox. We know women are more prone to gallstones, so that explains part of it. But the text delves into the hormonal aspect. They've looked at progesterone and estrogen receptors in the tumor tissue.
And this is where it gets kind of counterintuitive. You'd think if hormones drive the cancer, having receptors for those hormones would be a bad sign.
You would think so, but the data suggests the opposite. The presence of estrogen, or progesterone receptors in the cancer cells, is actually associated with earlier stages and a better prognosis.
So if the tumor is still listening to the hormones, it's acting less aggressively.
Essentially, yes. It implies the cells are more differentiated. They still look and act somewhat like normal gallbladder cells. When you lose those receptors, it correlates with advanced, undifferentiated metastatic disease. It's a marker of how far the cancer has gone rogue.
Let's move to the clinical reality then. A patient comes in. What are they complaining of? Or is the problem that they aren't complaining of anything until it's too late?
That is the Achilles heel of this disease. The symptoms are just tragically nonspecific. Right upper quadrant pain, maybe some nausea, intolerance to fatty foods. It mimics benign biliary colic, a simple gallbladder attack, almost perfectly.
So a GP sees this and thinks, it's just stones, let's schedule an ultrasound, not realizing there's a malignancy brewing.
Precisely. By the time a patient presents with jaundice, weight loss, or a palpable mass, you are almost certainly looking at advanced disease. It's often unresectable at that point.
Which brings us to this concept of incidental GBC. The text suggests that in the West, this is actually the most common way the cancer is found.
It's a massive portion of cases, sometimes over 50% in Western series. Picture this. A patient goes in for a routine elective cholecystectomy because their gallstones are bothering them. The surgery goes fine, the gallbladder comes out, everybody goes home happy.
And then 3 days later, the phone rings.
And it's the pathologist. That routine specimen had a surprise inside. Adenocarcinoma. It's a nightmare scenario for the patient, obviously, but it's also a pivotal moment for the surgeon because the next steps are life and death decisions.
This leads us right to staging. If we catch it largely by accident, we need to know exactly how deep it goes. The T stage seems to be the single most important variable in the entire book.
If you take nothing else away from this deep dive, memorize the T stages. The depth of invasion dictates survival. We are looking at the difference between T1A, T1B, and T2.
Okay, let's break those down. T1A versus T1B. To a layperson, they sound like the same category, just splitting hairs.
But anatomically, they are worlds apart. T1A means the tumor is confined to the lamina propria, the inner lining. T1B means it has invaded the muscle layer.
Why does hitting the muscle matter so much? In other organs, the muscle isn't the final frontier.
This is where the gallbladder is unique. It is an anatomical outlier. The gallbladder lacks a submucosa.
Wait, really? The stomach has a submucosa, the colon has a submucosa.
Correct. In those organs, the submucosa acts as a robust barrier. It's a safety buffer. The gallbladder doesn't have it. So once the cancer hits the muscle layer, T1B, it has very easy access to the lymphatic and venous drainage. And where does that drainage go?
Directly into the liver.
Directly into liver segments, IV, B, and V. So a T1B tumor is already knocking on the door of the liver, whereas a T1A tumor is still safely contained within the lining.
That explains why the imaging is so critical. Ultrasound is the first line for stones. But is it useless for this kind of staging?
Not useless, but limited. Ultrasound is great for seeing stones in fluid. It's terrible at seeing early, flat, neoplastic lesions. It often just looks like a thickened wall, which you'd see in regular cholecystitis anyway.
So if you suspect cancer, or if you need to stage it, you have to upgrade.
You need a contrast-enhanced CT scan. That is the cornerstone. You need to see if the liver is infiltrated, if the portal vein is involved, or if there are lymph nodes lighting up. And if you suspect the bile ducts are involved, you need an MRI or MRCP to map out the plumbing.
Okay, let's go into the operating room. We've got our diagnosis. Maybe it was incidental, maybe it was caught on a scan. We know that surgery is the only potential cure.
The only cure. And the goal is an R0 resection microscopically negative margins. If you leave cancer cells behind, the game is lost.
So let's play out that incidental scenario. The pathology report comes back, T1A. The gallbladder is already in a biohazard bag somewhere. Do we need to call the patient back for more surgery?
In the case of T1A, you can breathe a sigh of relief. A simple cholecystectomy is usually sufficient. The long-term survival approaches 100%. You don't need to go back in.
But if that report says T1B, if it touched the muscle,
then simple removal is absolutely not enough. This is the controversial pivot point where inexperienced surgeons might hesitate, but the data is clear. T1B mandates a radical cholecystectomy.
And radical here isn't just a buzzword. It implies a significantly more aggressive procedure.
Much more aggressive. You aren't just taking the gallbladder, you are taking a wedge of the liver, specifically segments IVB and V, and you are performing a regional lymphadenectomy to clear the portal and hepatoduodenal nodes.
It seems like a huge escalation. You're cutting out a piece of the liver because the cancer touched the gallbladder muscle.
It feels aggressive, I know, but remember the missing submucosa. The risk of microscopic spread into that specific liver bed is high. Even if you can't see it with your eyes, the cells might be there. If you don't take that wedge of liver, you are leaving the seeds of recurrence behind.
And what about T2? That's where it's gone through the muscle into the connective tissue.
T2 gets treated the same way as T1B radical cholecystectomy. The debate really only exists at that T1A, T1B border. Once you are at T2, Everyone agrees you need to clear the liver bed and nodes.
What happens if the surgeon opens the patient up and sees peritoneal carcinomatosis, little spots of cancer, all over the abdominal lining?
Then you close. Surgery is contraindicated, it won't cure the patient, and it will only delay the systemic therapy they desperately need. The same applies if there is bilobar liver involvement, meaning it's in both the left and right lobes. You can't resect the whole liver.
That's a grim reality. So for those patients, or for patients who have had surgery but have a high risk of recurrence, we turn to systemic therapy. The text mentions recurrence rates are high.
Extremely high, up to 70% after resection. So adjuvant therapy chemo after surgery is critical.
What is the weapon of choice here?
For a long time, we didn't have a standard, but the ABC02 trial changed that. This was the landmark study for advanced biliary tract cancers. It compared gemcitabine alone versus gemcitabine plus cisplatin.
And the combination won.
It did. It improved survival to 11.7 months compared to 8.1 months.
I have to be honest, hearing 11.7 months as a victory feels heavy. It really shows how difficult this cancer is to treat.
It is sobering, but in the context of biliary cancers, that 3-month gain was statistically significant and established a new standard of care. It's the benchmark we measure everything else against.
And then for adjuvant therapy, specifically for people who have the surgery, we have the BILCAP trial.
BILCAP looked at capecitabine. It showed an improvement in overall survival for patients who had their cancer resected. So the current playbook is, if you cut it out, you put them on capecitabine. If you can't cut it out, you give them gemcis.
Is there any room for radiation? I feel like radiation is standard in so many other tumors.
In GBC, it's a bit of a Wild West. The evidence isn't as robust as in, say, rectal cancer. However, the source details the SWOG S0809 trial.
Tetchy name.
It's a phase 2 trial, so not the final word, but it showed promise for adjuvant chemoradiation drugs plus ZAP. It was particularly beneficial for patients with an R1 resection.
R1 meaning the surgeon couldn't get it all. There were microscopic cells left at the margin.
Exactly. In those cases, directing radiation at that liver bed helps sterilize the area and kill those stragglers. It can turn a partial success into a better long-term outcome.
Okay, we've covered the standard slash and burn surgery and chemo. But the promise of this deep dive is to look at the future. The source material spends a significant amount of time on the molecular frontier.
This is where the hope lies. We are trying to transition from viewing GBC as purely a surgical disease to a molecular one. We are using genomic profiling to find the specific mutations driving the tumor.
One of the heavy hitters mentioned is HER2.
Mm-hmm.
I usually associate HER2 with breast cancer.
Most people do, but HER2 or ERBB2 amplification is actually more common in gallbladder cancer than in other biliary cancers like cholangiocarcinoma. It's a major differentiator.
That's huge because we already have drugs that target HER2.
Exactly. We don't have to invent a new molecule.
Yeah.
We can look at drugs like trastuzumab and lapatinib. The text mentions studies where combining chemotherapy with trastuzumab showed enhanced cytotoxicity, better killing power, especially in those tumors with high HER2 amplification. It's about taking tools we already have and applying them to a new target.
It's repurposing at its finest. What about the EGFR pathway?
That's another big target. EGFR overexpression is seen in anywhere from 11% to 100% of cases, depending on which study you read.
That is a wildly wide range.
It is, which reflects the heterogeneity of the disease. We've tried drugs like erlotinib and cetuximab. The results have been, well, mixed, some modest improvements, but not the home run we saw with HER2.
And then there's the blood supply, VEGF.
Vascular endothelial growth factor. Tumors need blood to grow. GBC often has high levels of VEGF-A. So using bevacizumab Avastin to starve the tumor of its blood supply has shown improved response rates in combination with chemo.
So we had targets on the tumor cells, targets on the blood vessels. And then there's this really specific mutation mentioned for a gene called ELF3. This felt like the sci-fi moment of the text for me.
This is the work by Pandey and colleagues. It is a breakthrough concept regarding vaccines.
Vaccines to treat the cancer, not prevent it.
Right. They identified frame shift mutations in the ELF3 gene. Interestingly, this mutation varies by region. It's more common in the American and Chilean samples than the Indian ones.
What does this mutation actually do that helps us?
It creates neoantigens. When the DNA shifts, the cell starts producing proteins that look completely alien to the body.
It puts a flag on the cancer cell saying, I don't belong here.
Exactly. And because they are foreign, they are capable of activating CD8 plus T cells, the hunter killers of the immune system.
So the strategy is to synthesize these alien proteins, put them in a vaccine, and train the immune system to hunt down anything carrying that marker.
Precisely. Peptide vaccines. It shifts the paradigm from poisoning the tumor with chemo to training the body's own defenses to recognize the specific genetic typos of the cancer. It's precision immunotherapy.
That is incredible. Before we wrap the molecular section, we should touch on epigenetics. This isn't about the DNA code changing, but how it's read.
Right. Methylation. Think of it as gumming up the lock so the key won't turn. In GBC, we see hypermethylation of tumor suppressor genes like P16 and PTN.
These are the genes that normally put the brakes on cell division.
And the cancer effectively turns them off by methylating them. The hope with epitherapy is to use drugs to reverse that methylation, clean the gum out of the lock, and turn those tumor suppressors back on.
It's almost like rebooting the cell's safety software.
That's a great way to put it. It's still early days compared to surgery, but it shows how many angles we are attacking this from.
This has been a whirlwind tour of a very small but dangerous organ. Let's try to synthesize this for our listeners. We have an aggressive cancer, strangely linked to large gallstones and female hormones.
Diagnosis is almost always late or incidental. Staging relies heavily on that T1A versus T1B distinction. The muscle layer is the line in the sand.
Surgery must be radical, taking the liver wedge if the muscle is involved.
And systemic therapy is evolving from basic GemCis to potentially HER2 targeting and ELF3 vaccines.
All right, to make sure this sticks, let's do a quick review exercise. A board exam style scenario for the medical professionals listening.
Let's do it.
Here's the scenario. You have a 60-year-old female patient. She undergoes a laparoscopic cholecystectomy for symptomatic gallstones, routine procedure. 3 days later, pathology comes back. It's adenocarcinoma. The report says the tumor has invaded the muscle layer, making it T1B.
A classic presentation.
The question is the simple cholecystectomy she just had sufficient? Can we just monitor her?
The answer is an emphatic no.
Walk us through the why.
Because it is T1B. It has invaded the muscle, remember the anatomy, no submucosa in the gallbladder. The risk of microscopic residual disease in the liver bed and the regional lymph nodes is unacceptably high.
So what is the next move?
She needs to go back to the operating room. She requires a radical cholecystectomy. You need to resect liver segments IVB and V and perform a porta-hepatis lymphadenectomy. If the pathology had said T1A lamina propria only, she would be cured. But T1B mandates radical surgery.
Clear and actionable. It really drives home the importance of that pathology report.
It does, and I'll leave you with one final thought. That scenario highlights why routine histopathological examination of all gallbladder specimens is so important. In some resource-limited settings, or just out of habit, if a gallbladder looks normal after surgery, they might not send it to pathology to save costs.
That sounds like a dangerous gamble.
It is. Because incidental cancer is the most common presentation of curable disease. If you don't look, you don't find it until it comes back as stage IV. So always check the pathology.
The crucial reminder, always check the work. That wraps up our deep dive into gallbladder cancer. It's a complex disease, but understanding the anatomy and the molecular profile gives us a fighting chance. Thanks for listening, and we'll see you on the next deep dive.